what are the most common challenges ICU physicians face in managing carbapenem-resistant infections, and how have treatment approaches evolved in recent years?
So I think all those who are working in intensive care units pan India are facing this problem about the carbapenem-resistant infections, and it has been a big bane for all the intensivists and physicians because it leads to high morbidity, high mortality, length of stay, cost of the therapy, everything goes up. And also the problem is the side effects of the high because of these high-end medications, which need to combat these problems. Almost, I would say, CRE has become 30%. Up to in some studies have shown that up to 60% of the gram-negative bugs which are isolated in various ICUs are carbapenem-resistant Enterobacteriaceae. So I think this is the major problem which is there in pan
Okay.
ICUs. Yeah.
Okay. So next question to you. Regarding empirical therapy decisions in critically ill patients with suspected carbapenem-resistant infections, what are the best empirical treatment strategies before definitive susceptibility data are available?
Okay. See, if we go back in history, I'll be a little elaborate on that. If I talk about 2006, when we came into intensive care, third generation cephalosporins used to work wonders.
Exactly.
And then came BLIs, if I'm not wrong, in around 2008 and 9. Carbapenems were still reserved drugs and hardly available. And by 2010, carbapenems were labeled as workhorses of all the ICUs. And now those workhorses have failed. And it's a disaster. We really have been left with no choices presently except for newer BLI combinations, but that too in Indian setups because of NDM and other resistance patterns, it doesn't work. So ultimately, we are left with colistin and polymyxin as last choices. But again, those are static drugs. You have to be very careful. And when you do receive your culture reports and susceptibility reports, you have to look at even their MIC values and then decide whether they will be really effective or not. And sometimes then even combination therapy has to be used if it is really intermediate.
Okay. Okay. So next question to you regarding combination therapy and monotherapy in ICU practices. So what is the current evidence on combination therapy versus monotherapy for carbapenem-resistant infections? And are there specific pathogen drug combinations that have shown better clinical outcomes? My question basically is, are there any specific pathogen and specific drug combinations which will be
Yeah.
more
So,
effective?
so first, answering the first question, monotherapies usually are not working at all now in many ICUs, and that has failed. So what probably earlier we were using the trials and research had come about the use of high dose polymyxins and high dose colistin along with high dose carbapenems. So that was the thing which came up. Now recently newer molecules have come like ceftazidime, avibactam along with estonam. So specifically for Klebsiella infections and Astrobacter infections, these, as you said about the pathogen specific. So for these drugs, they have shown to be far more better in terms of potency and in terms of less number of side effects. But one thing one need to remember is that when we are using ceftazidime, avibactam along with estonam, they have to be given simultaneously. Infusions have to be given simultaneously, and also our microbiology needs to be geared up whether they can do a synergistic testing, whether it will work or not. If they don't have those facilities, sometimes we might fail in our therapies.
Okay. So next question to you regarding novel and alternative agents. So with newer antimicrobials like cefiderocol, how should ICU physicians decide between traditional options like polymyxins and these newer agents?
See, say, for newer agents, cefiderocol is not freely available in
Yes.
our country yet. So we'll talk about what is available with us. We have to remember here the newer BLBLIs, like sir mentioned, ceftazidime, avibactam, it can work for CREs, but it has no role in crabs. Avibactam does not cover Acinetobacter baumannii, and we should remember that. And the only choices we are left for crab is polymyxins or colistin. And for that also you have to combine it with sulbactam high dose. This is the only option left. Combining it with even carbapenems doesn't work because the carbapenem resistance is almost more than 80% now. So combining high-dose sulbactam with polymyxin for CRAB and newer BL-BLI combinations for CREs, those are the choices we are left with.
Okay.
And also, regarding that, as Dr. Saab is saying, cefiderocol is not available in Indian scenarios. So we have got off, we used few patients, 5, 6 of patients, cefiderocol. First of all, the costs are prohibitive. The patients are, by the time you start, clinicians start looking into cefiderocol, patient is already in multi-organ failure. And, just as the last resort, on the request of the patient's relatives and frustration, we used it. So probably till we have it routinely available, maybe
So
it's,
basically the comorbidities are so much that it is anyways going to fail.
yeah. So it was a mixed result in us. Now we don't know whether a couple of patients who survived, whether it's because cefiderocol or they just improved on their own with other therapies. So
I
that's a
guess
big
what point
question.
sir wants to make here is early therapy with cefiderocol would have been
Yes.
more
More
effective,
beneficial to
but
the
because of not freely available, even if you want to give it, it will take 48 hours for the drug to reach to you.
Correct.
So by the time patient's condition would have deteriorated further, and in
Yeah,
any septic patients, golden rule is hit soon, hit fast.
Yeah. So next question to you. What are the key reasons for treatment failures in ICU patients with carbapenem-resistant infections, and how can resistant mechanisms be better identified and counteracted?
So as sir has already highlighted that part, the first and foremost is you have to think about whether this patient is suspect strongly having carbapenem-resistant infections or not. Most of the time, most of us are, if are working in a secondary or tertiary care units, they've already received second line, third line therapies already, and they come to us in a pretty bad state. Now, so if you have you have antibiograms of your hospital, what are the susceptibility patterns of your hospital, maybe you can start empirically the therapies based on those, and then if you have a definitive culture sensitivity available with you, then you can de-escalate or tailor-made as per the clinical scenario. Although also other things are, we can use good use of PCRs, polymerase chain reaction based techniques, carba-R, etc. They really help in tailoring made for situations in titrating, and also deciding which therapies are better suited for those type of patients.
Okay. Our last question for the session. Sir, regarding stewardship practices and de-escalation practices. So how can ICU physicians integrate antimicrobial stewardship principles when treating carbapenem-resistant infections to balance efficacy, toxicity, and resistance prevention?
See, antimicrobial stewardship programs are definitely required, but in Indian setups, they are very difficult to follow, especially with we don't have closed ICUs. Whenever responsibility sharing is there, you have to discuss with your fellow colleagues. So what we have done is introduced forms for AMR in our, whenever you have to use any reserved drug, primary physician is made to sign that form and justify its use. So that way we have come down on usage of, like phosphomycin was being used for pyelonephritis, though it doesn't have any parenchymal penetration. So we need to, argue with them or discuss with them every aspect of which drug will be effective where. So it's a common practice, phosphomycin being used for pyelonephritis, but it doesn't penetrate parenchyma, so there is no point. It's only for urinary tract infections. So that way, in the initial stages when 2015-16, I had to convince patient that polymyxin will not be effective for Acinetobacter in urine. You have to use colistin there. Polymyxin does not penetrate urinary. So those are you have to see a lot of pharmacodynamics and kinetics of the drug. What is the tissue penetration for lung? You have to consider ELF of the particular drug. So all these factors have to be considered before selecting a drug, and then based on the host factors. That is another important thing. Combination therapy in the initial unstable phase, and then monotherapy, or then once absolutely stable and you have achieved the desired response, de-escalation as early as possible. I do it even on third day if patient is stable, but that is usually, you again have to justify that. There are issues of relapse, especially with Acinetobacter. In the seventh day you have to escalate again, but then question arises on your judgment, but then you have to be very sure about your
Will it
de-escalation
cause
principle.
resistance in that case or no?
Yeah.
Also, probably one look can also look into for the younger colleagues. I would say that if patient is maybe started on say a couple of gram negative antimicrobials plus teicoplanin, plus say fluconazole, maybe you can, once you have some sensitivity or some infection etiology, I don't know, you can stop teicoplanin fluconazole, because now it's going to work in Astrobacter or
Yes.
Klebsiella or Pseudomonas. So maybe that form de-escalation is also very important. So I think if we can, as Dr. Saab is saying, ki de-escalation to the lower end of antibiotic, that's an ideal case scenario. But if because of certain factors, because of your colleague's pressure, you may not be able to do it, then probably stop gram-positive and antifungals, which anyway are just putting the financial burden on the patient.
I would like to close the session and thank you both of you, sir,
Thank you.
and thank you for the audience for your patient listening. Thank you.
Thank you.